and these 2 incisors. This canal we are not going to touch. So totally 3 implants. I don't know whether we can place 3 or 2. We'll see. So lower anterior is the most commonly encountered replacement. For beginning, it is very easy to start. Anyway, it works very well. The only golden rule is respect the resistance. Don't place implants too close to each other. These 2 things. Don't focus on the number of implants. Don't try to place 4 implants between incisors.
Sir, I will send you a DICOM file. You please guide me for this, the angulations and everything.
Okay. So this is the clinical picture. The upper also is trouble, but we are going to deal later. Periodontitis, gradual proclination, spacing. These 2 teeth automatically fell down because of periodontitis. This is 4-3. This is 4-3, which we are not going to remove. This is good. 4-2 is mobile, and 3-3 also we are going to remove. 3-3 we are going to remove these 2 incisors. 1 implant here, 1 implant here, 1 implant maybe here
in the center.
Because if you place 2 implants here, they may be close to each other. So here, next to this incisor.
In the midline.
Next to midline. 3-1. 3-1. Okay. So 1 implant here.
Okay.
1 implant here and 1 implant here, next to this.
Okay.
If you are in doubt, you can easily open the flap.
Okay.
The small flap, what is the big deal? Or if you are confident, you can do flapless also. We will see the panoramic view. So as usual, how many implants? 3 implants we decided that. Location we decided that 1, 2, 3. Now you have to decide whether compressive or basal.
Compressive.
Yeah, compressive. If the buccal bone defect is there, good. There is no buccal bone defect. Compressive. 2, 3 compressive. If there is some
bone defect, then basal.
Go for basal. That's it. So diameter mostly below 4 for anterior.
Yes.
So the length is determined definitely by
resistance.
Resistance. That's it. You cannot measure the length here.
Okay.
Because it looks. No, you can drill from here to here, but actually it will be a C shape. You cannot do that. So we will place 1. So if you place along the long axis of the tooth, you will feel the interference in here, right? So we'll add the abut materials. So along the long axis of the thing you can drill.
C shape.
Yes, C shape. So C shape. So the problem with C shape is, if you follow the long axis of the tooth, you will perforate again. If you do alveoplasty till here, you can place implant straight. But without doing alveoplasty, can you place straight? This bone will prevent. This bone will prevent. Otherwise, open a minimal flap, do a minimal alveoplasty, and you can start drilling close to the lingual plate. But the abutment will come too lingually. It will interfere with the current. Then you have to bend labially. Okay, otherwise follow here. Okay, and go till here. Whatever length comes, you can do it. Or what we will do is, after extraction, what we will do is, we will do the drilling close to the lingual cortical bone, and we will get some more length. If you go like this, you will soon hit the resistance if we go like this, can get some more length and we will finally hit this resistance. The abutment we can bend slightly later. So our plan is extract, keep the drill close to the lingual plate until wherever you are feeling resistance, stop it and measure it and place it. So if we are doing drilling like this, I'm just drawing the diagram like drill. It will go like this, right? So lot of length we can get, 18 mm also we can get. So clip on some point 18 also we can get this. So the second implant is left canine. First see the shape that guides our surgical technique more than anything else. It is C shape. And we cannot do plastic. So the drilling, we have to be very careful. Most of the time the drilling will come here and it will hit here. We have to feel the resistance, respect the resistance, measure the drill length, then select either BCS or compressive. Okay. But here the bone quality is little bit poor, right? If you place BCS, it will get only from here stability. Yes. But if you place a compressive, it will get stability from here also.
Yes.
So in those kind of situations, BCS EX will help. Okay, the bigger design. So crystally,
2 to 3.
Yeah, 3 mm of
smooth
micro threads. Then 3 basal threads. Then again
micro threads.
compressive threads. The good thing about this design is it is smooth surface. So even if this bone resorbs later, it doesn't matter. So this kind of little osteoporotic cases, we can try BCS EX treatment. 17 are there. 19. Okay. And third implant is almost in the 3-1 area. So it is beautiful bone, right? And we can see the two lingual canals. Can you see? See the canal, the lingual vessel. Here one, here one. So that is why it is better to keep the implant length short. A very short implant is enough. The bone is very much dense. So when the bone is very much dense, you should be very, very careful. There is a more chance that you may break the drill, break the implant. So more drilling you should be doing here. Otherwise, Dr. Medilla, first implant I broke. Okay, that is because so much of resistance you will feel. Even till here, even after reaching till here, no, you will feel resistance. So a short implant, 3 point something into your 11.5 is enough. No need to select a longer implant. There is no point in going till here. What is the use in it? Just a short implant is enough, which is 13. Even 13 is not needed. 11.5 is enough. You will get enough stability from this part. So this bone is called marble bone. Absolutely no blood supply here. Okay, D1. So D2, D3 is good for implant.
Okay.
D1 also bad, D4 also bad.
Okay.
So whenever you see this kind of bone, do more drilling.
Okay.
Okay. Otherwise, there will be bone necrosis, pain, the implant rejection may happen. So when the bone is too dense, also you have to be careful. When the bone is too osteoporotic, also you should be careful. We'll start.